Okay. So, good evening and welcome to all the faculty members and delegates to the HER2 in other solid tumors. We are looking forward to an insightful and engaging event together. Before we begin, just a quick note on how you can participate. If at any point you have a question for any of our speakers, please use the Ask the Question button at the bottom of your screen. Feel free to type your questions throughout the session. We will address as many as we can during the Q&A segments. Now, let us begin with our agenda. It is my pleasure to introduce our first speaker, Dr. Shayana Dawood, ma'am. She is a consultant and a professor at the Department of Medical Oncology at Mediclinic Hospital, Dubai. Over to you, ma'am.
So thank you for the invitation and thank you for the lovely introduction. Let me just open my slides. Please let me know that you can actually see my slides.
Yeah, they're visible, ma'am.
Oh, excellent. So all right. So so this is I think the third lecture in this series, and today I'm going to give a talk on a topic that I think is truly fascinating, because all of us have trained in medical oncology at a time and an era where we had one target, one malignancy. And to actually move into an era where you have one target, all malignancies, where you're moving into an agnostic approach in terms of therapeutic management is truly fascinating. These are my disclosures, and if anyone would like to get in touch with me offline, please scan the QR code. I'd be more than happy to network. So as I said, this is the era of precision medicine. We've moved from that one target, one malignancy, to really looking to profile tumors so that we can personalize therapeutic management of our patients. And what you see here on this slide is really looking at patients that come in with malignancies. You profile their tumors, and you get a lot of information on prognostic markers, markers predictive of drug sensitivity and resistance, markers predictive of adverse events, and all this information put together can actually allow you to individualize therapeutic management of patients. We know that biomarkers inform therapy. You can identify genomic alterations that are drivers of tumor growth and progression. You can identify those genomic alterations that are targetable either directly or indirectly. They can be mutations, copy number changes, or even fusions. And of course, those other biomarkers such as immunohistochemical biomarkers like MMR, biomarkers, and HER2. Now, we've had a plethora of different agents approved in the agnostic realm. Remember, one drug, one target, all malignancies. That's the way I see agnostic tumor approvals. It really started in 2017 when we saw pembrolizumab actually approved for any patient who had MMR deficient disease. 2018. In 2019, we saw drugs approved for NTRK fusions. I have a patient currently with metastatic melanoma and metastatic breast cancer who's been treated with entrectinib, who's been in complete remission for 5 years, and in terms of this agnostic approval. In 2020, we saw pembrolizumab approved for TMB high tumors. And then, of course, we saw medications approved for BRAF mutation-positive tumors, silpercatinib for RET fusion tumors. And by May 2024, we saw the marker in terms of immunohistochemistry, HER2-positive tumors, being treated with trastuzumab deruxtecan. Now, the frequency of these agnostic markers are visible on the screen over here across different solid tumor types, different incidences, but in general, they're not very, very high. But I've always said you need to find that N of 1 that can actually try and help you save that patient. And if you don't test, you will never find that N of 1 patient. Now let's focus on the targeting of HER2, because that's the topic of today, in which we know that in breast cancers, standard of care to test for HER2 way back in 2001, Slayman and colleagues actually showed that in patients who had HER2 overexpressed or amplified metastatic breast cancers, when you gave them trastuzumab-based chemotherapy, it improved not only progression-free survival, but overall survival of these tumors. Since then, we've had multiple drug approvals. We've had 3 other antibodies that have been approved including trastuzumab, pertuzumab, and margetuximab. We have small molecule inhibitors such as tucatinib and neratinib. And of course, we've got those antibody drug conjugates such as TDM1 and trastuzumab deruxtecan, all targeting that HER2 pathways. Now, HER2 alterations can either be amplifications, overexpression, as well as mutations. And we should not forget that. It's important to recognize it's not only about testing for HER2 amplification and overexpression, but also HER2 mutations for which we have antibody drug conjugates. And what you see on the slide over here is the different incidences in terms of amplification, overexpression, and mutations across different malignancies. But across the board, when you look at this particular data sample of almost 37,000 samples, you can see approximately 3% of patients across different solid tumors will actually have an IHC3 plus for HER2 overexpression, which actually increases more enriched in patients who have bladder cancers where it can reach almost 12.4%. But it's not only about amplification and overexpression in HER2 mutations, but also looking at those patients who've got HER2 low or ultra low expressions. And those are patients with 1 plus, 2 plus, or ISH negative. Well, we have to recognize that ADCs do have a role, and we've shown that in breast cancer. And here you see a cohort of patients, 4,700 patients that underwent HER2 testing. Nearly 50% of these patients had some level of HER2 expression across a plethora of different solid tumor types, 8.7% 3 plus, 16.9% 2 plus, and about 24.2% of patients had 1 plus expression. But what I liked about this particular cohort study was they also looked at the methodology of trying to identify HER2 expression. And what they essentially showed was that most, but not all tumors that are amplified on next generation sequencing also had overexpression on IHC. But not all patients with HER2 expression or overexpression have HER2 amplification on NGS. So again, very important that when you're actually reading something, that you find out, is it by NGS or is it by our traditional IHC versus FISH or ISH testing? Now, in terms of looking at those multiple anti-HER2 agents that we have in our clinic, we have agents that target HER2 signaling, such as monoclonal antibodies, trastuzumab, pertuzumab, the bispecific antibodies, zanidatamab. And then you have the small molecule inhibitors, like I've just talked about, tucatinib, lapatinib, neratinib. These all target the HER2 signaling pathways. We've also got medications that are targeting HER2 for immune strategies, such as bispecific engagers. CAR Ts are now coming up in this realm, including vaccines. And of course, you've got those antibody drug conjugates that have cytotoxic payloads that actually help us better improve therapeutic management of our patients. Now, of course, the new kid on the block, which is what we're going to be focusing on today, is trastuzumab deruxtecan. You've seen this slide so many multiple times. It is a HER2-directed antibody drug conjugate with at least 7 key attributes, including having a topoisomerase inhibitor payload. It has a high potency of payload. The payload has a short systemic half-life. It is highly membrane permeable, which may enable a bystander effect, which we like to see, especially in those heterogeneous tumors. It is stable in plasma. It is designed to be cleaved by lysosomal enzymes that are overexpressed in tumor cells. And of course, it has a drug to antibody ratio of 7 to 8. Now, we've all seen this slide before. We know that in breast cancer, HER2 positive, we first saw the results of the Destiny Breast 03 trial that established TDXD in that second-line setting in patients HER2 positive that had progressed on trastuzumab, pertuzumab, randomizing them to get either TDXD or TDM1, and TDXD quite clearly trumped TDM1. This year at ASCO, we saw the results of the DB09 trial that has now taken TDXD into that first-line setting where it's trumped the Cleopatra trial in terms of those patients who've got HER2 positive breast cancer. But how much HER2 is actually needed for TDXD activity? And we saw this last year at ASCO, where Giuseppe Clugliano actually showed that when you're using TDXD, even in those patients with HER2 low, which constitutes about 60 to 65% of our patients with hormone receptor positive breast cancer, or HER2 ultra low disease, TDXD actually can work. We saw the results of the DB06 study. DB06 showed us that in patients with HER2 low or ultra low disease, if you randomize them post-endocrine therapy to either get TDXD or physician choice of chemotherapy, TDXD trumped physician choice of chemotherapy, improving progression-free survival by about 5 months in patients HER2 low, as well as patients who have HER2 ultra low disease. Now, the growing importance of HER2 expression as a biomarker across multiple cancers is largely driven by advances in HER2-directed antibody drug conjugates. And this is where TDXD has really shined in terms of being applicable across solid tumor types. So in 2025, can we use TDXD across solid tumor types? Simple answer is yes. But let me walk you through the different malignancies. I've already showed you in HER2 overexpressed breast cancer, it works very well. It works in breast cancers that have HER2 low and ultra low disease. Now let's look at does HER2 targeting actually work in gastric cancers? Now we know in gastric cancers, 12 to 20% of gastric cancers are actually HER2 positive, either HER2 overexpressed or amplified by ISH testing. We've seen the results of the TOGA study, which was a first-line study in patients with metastatic gastric cancer or gastroesophageal cancers, where patients were randomized to trastuzumab plus chemotherapy versus chemotherapy alone. You can see that adding trastuzumab to chemotherapy significantly improved overall survival of these patients. This led to the Keynote 811 trial that took patients HER2 positive metastatic gastric or gastroesophageal cancers where they were HER2 positive, randomized to get either pembrolizumab, trastuzumab plus chemo, or just trastuzumab plus chemotherapy. Primary endpoint was progression-free survival and overall survival. And what they showed was that in those patients that were PD-L1 positive, which was the majority of the cancers, they found that adding pembrolizumab to trastuzumab plus chemotherapy trumped looking at only trastuzumab plus chemotherapy. You can see the overall survival improved from 16.8 months to 20 months. Question was, what could you do upon progression of disease in these HER2 positive gastric or gastroesophageal cancers? And this led to the Destiny Gastric 04 trial that randomized patients. Again, they had to be verified that they were HER2 positive post-progression on therapy to either be randomized to TDXD versus ramucirumab plus chemotherapy that was taxane-based. Primary endpoint was overall survival, and you can see a clear-cut improvement in overall survival with TDXD. It improved from 11.4 months to 14.7 months. Now, there's so many different anti-HER2 agents that are on the horizon in patients with gastric cancers and gastroesophageal cancers that are HER2 positive. You've got zanidatamab in advanced HER2 positive cancers. They've shown some nice data overall response rate in those heavily pretreated group of patients, almost 36%. We've seen the combination of margetuximab plus pembrolizumab in patients with gastric or gastroesophageal cancers, HER2 positive, again, overall response rate about 30%, with a median overall survival about 14 months. Now, what's even more interesting is that we've seen also in the Destiny gastric studies that even in patients with HER2 low, that is IC2 plus, ISH negative, or IC1 plus, where giving trastuzumab deruxtecan was associated with a very decent overall response rate of about 30%. In patients with IC2 plus, ISH negative, and a very decent progression-free survival of about 4.4 months, telling us that we can broaden that activity within the realm of these patients with gastric gastroesophageal cancers. Now, what about colorectal cancers? Can we in fact target HER2 in patients with colorectal cancers? Now, we know colorectal malignancies, we have to look at multiple targets because it's not homogeneous in itself. There are different targets that we can actually use medications for. We've got the RAS wild type where we use anti-EGFR. 40% of these patients have RAS wild type disease. BRAF mutations, where 8% of these patients can actually benefit from targeted therapy. MSI high patients, 5% of these patients can actually get immunotherapy. Of course, there's agnostic markers like TR and TRK fusions. Less than 5% of these patients can actually benefit from this. But 5% of patients with colorectal cancers actually have HER2 positive disease, either overexpressed or ISH positive. Now, there's been a lot of different clinical trials that have looked at targeting HER2 in colorectal malignancies. We know that abnormal HER2 gene function is about 3% overall, but we know that amongst patients who've got RAS wild-type disease, about 6 to 8% of these patients. You have the Heracles A trial that looked at combining trastuzumab plus lapatinib in a heavily pretreated cohort of patients. Overall response rate was about 30%. The Heracles B trial looked at pertuzumab and TDM1. Overall response rate was about 10%. There was a Summit trial that looked at neratinib in those patients with HER2 mutations, and they didn't get much of a response in this cohort of patients. The My Pathway trial was very interesting, where they gave a combination of trastuzumab, pertuzumab, where they got an overall response rate of 32%, mainly in those patients with wild-type disease. And you can see the progression-free survival in the wild-type, RAS wild-type disease, 5.3 months. Then came the Destiny trials. You had the Destiny CR01 and the CR02 that actually asked the question, is TDXD efficacious amongst patients with HER2 positive colorectal malignancies? So let's look at the Destiny CRC01 study. It was a multi-center study, phase 2, that looked at trastuzumab deruxtecan in a heavily pretreated cohort of patients. 30% of these patients had received prior anti-HER2 therapy, 100% had received prior irinotecan-based therapy, and you can see the overall response rate, very decent overall response of 45.3%, disease control rate of 83%, progression-free survival of 6.9 months, and an overall survival of 15.9 months. And no responses were actually seen in that HER2 low subgroup of patients who had an IC1 plus or 2 plus. We saw the Destiny CR02 trial that looked at patients with RAS wild type or mutant disease, and BRAF wild-type disease that was unresectable. And these patients were randomized to get either TDXD at 5.4 milligrams or 6.4 milligrams per kg. The primary endpoint of this trial was overall response. So you can see the overall response rate was in fact 31%, with a disease control rate of 71% and a median duration of response of 5.5 months. When you're looking at the progression-free survival in the 5.4 milligrams per kg, was about 5.8 months, and very similar with the higher doses, which is why we tend to use the 5.4 milligrams per kg in our patients in the clinic. When you're looking at the overall survival, it's about 13.4 months in the patients who received the 5.4 milligrams per kg. When you're looking at that forest plot, I really like this forest plot because we know that trastuzumab, pertuzumab doesn't work that well in those patients with KRAS mutant disease. But here, what you tended to see was that in both patients, wild type and mutant, it was actually working. Trastuzumab deruxtecan, telling us it's really different from using anti-HER2 therapy with monoclonal antibodies such as trastuzumab and pertuzumab. We're seeing data coming out looking at zanitamumab, I cannot pronounce it very well, where we've seen some preliminary data looking at single agent zanitamumab in patients who are heavily pretreated, overall response rate of 38%, progression-free survival of 6.8 months. We set the stage for first line combination of FOLFOX plus zanitamumab with or without bevacizumab. Preliminary data was presented by Ra and colleagues at ESMO last year. Very interesting, where they got an overall response rate of 91%, a disease control rate of 100%, with a median progression-free survival that was not reached. So again, very interesting results, and I'm looking forward to seeing more data from this. Now, what about lung cancers? Can we actually target HER2 in lung cancers? And the simple answer is yes. We saw the results of the Destiny Lung 01 study that actually took patients. Again, these were pre-treated patients who had relapsed on standard of care therapy, non-small cell lung cancer. These were non-squamous patients who were randomized who actually were put in either one of two cohorts. Cohort 1 were those patients with HER2 overexpression, and cohort 2 were the HER2 mutated patients. Now, in the cohort 1 of HER2 overexpressors, using trastuzumab deruxtecan at 6.4 milligrams per kg resulted in overall response rate of about 34%, percent in the cohort 2, which were the HER2 mutated patients. When you gave trastuzumab deruxtecan, the overall response rate was about 50%. Disease control rate was about 84%, and the median duration of response was 9.3 months. When you looked at the progression-free survival specifically in the HER2 mutation cohort, it was about 8.2 months. That was associated with an overall survival of 17.8 months. And I can tell you, about 2 years ago, I had a patient in her 70s, adenocarcinoma, non-small cell, stage 4 disease. She had a HER2 mutation, and she told me quite categorically she wasn't going to take chemotherapy. And after a lot of discussion, we decided actually in the first line setting to give her trastuzumab deruxtecan, and she went into complete remission for 2 solid years before she progressed and eventually died. So again, telling us that this drug has very good activity in those patients with HER2 mutation, is currently actually being investigated in that first line setting. We've got the Destiny Lung 02 trial that's looked at trastuzumab deruxtecan in patients with non-small cell lung cancer and HER2 mutation. You can see an overall response rate of 49% with a median progression-free survival of 9.9 months. We've seen the BEAMIAN Lung 1 trial that's looked at another ADC, zongertinib, which is actually looking at those patients with HER2 mutations. You can see an overall response rate of 71% and a median progression-free survival of 12.9 months. Nonetheless, based on the Destiny trials looking at trastuzumab deruxtecan, it got FDA approval in patients with HER2 mutant non-small cell lung cancer who had progressed on first-line standard of care. Now, could we go beyond gastric cancers, colorectal cancers, and lung cancers, as well as breast cancers, to really target a more broader group of patients? And that was the basis of the Destiny Pan-Tumor 02 trial. This was presented by Funda Merrick from MD Anderson. She was the lead author of this particular study. It was presented last year at a couple of years ago, at ESMO. This was a very interesting study. This study took patients with advanced solid tumors not eligible for curative therapy. So these were truly metastatic patients who received at least 2 prior lines of therapy. And they took various solid tumors, including all gynae tumors, including endometrial, cervical, ovarian, bladder, biliary tract, pancreatic tumors, and of course, other tumors. And they had about 40 patients in each of these cohorts, and all patients received TDXD at 5.4 milligrams per kg Q3 weekly. These patients had to have HER2 expression either IHC 3+ or 2+. And the 2+ had to be ISH positive in some of the analysis, but they did look at those patients who are also ISH negative and IC1+ as well, and I'll show you that data later on. Now, when you look at the primary endpoint of the study, you can see the primary endpoint of the study was overall response across solid tumor types, including the gynecological malignancies. You can see in those patients who had IHC 3+, overall response rate was 61%. But even in those patients with IHC 2+, it's about 27.2%. The median duration of response in the IHC 3+ was 22.1 months, and the IHC 2+ was 9.8 months again. So again, I thought was very, very interesting results. And you can see across the malignancies, in those IHC 3+ patients, high overall response rates, but it was in the IHC 2+ where it's not that bad in terms of response rates. When you're looking at the progression-free survival and overall survival, you can see PFS in all patients was 6.9 months, but the PFS specifically in the IHC 3+ patients was 11.9 months. And when you look at the overall survival in all patients, it was about 13.4 months, but in the IHC 3+, it was about 21.1 months. Now, when you're subdividing into those different malignancies, again, you're seeing that across malignancies, endometrial cancers, cervical cancers, ovarian cancer, these are all the gynecological malignancies. And then you look at those bladder, biliary tract, those hard-to-treat tumors like pancreatic cancers, you're seeing efficacy with trastuzumab deruxtecan mainly in those IC3 plus patients. Now, specifically BTCs, these are difficult tumors. These are tumors where patients have a very poor prognostic outcome. We know that 20% of these patients will have HER2 amplification or overexpression, where you can potentially give them HER2-directed therapy. And when you look at the two HER2-directed therapies that are now approved for biliary tract cancers, you can see that in the Destiny Pan Tumor 02 trial, which I've just shown you, 41 patients with BTCs, you can see an overall response of 56.3% in those patients with an IC3 plus, and zanitimab, which is now approved based on the Horizon study, you can see an overall response rate of 38% in this cohort of patients. The side effects, very similar to what we saw in the breast cancer realm. You can see about 10% of these patients did have ILD, most of them being grade 1, grade 2. So this was what formed the basis of the FDA approval as an agnostic marker. You can see data from 192 patients from 3 trials: the Destiny Pan Tumor 02 trial, the Destiny Lung 01 trial, the Destiny CRC 02 trial. Conglomerately altogether resulted in the pan-tumor indication, agnostic indication for trastuzumab deruxtecan in HER2-positive solid tumors. I wanted to spend a little bit of time looking at those gynae tumors because I feel it's probably the most interesting aspect of the Destiny Pan Tumor 02 trial. And like I said, the highest response rate you get for TDXD in endometrial cancer, cervical cancer, and ovarian cancer are in those patients who have IC3+. But they also reported last year at the SGO meeting, or 2 years ago at the SGO meeting, that there was a very decent response rate even in those patients with IC2+ or 1+ in the endometrial cancer, cervical cancers, and ovarian cancers. In the endometrial cancer, you can see a progression-free survival in the IC3+ of not being reached, but in the 2+, you have a very decent to 11-month progression-free survival and about a 16.4-month in the IC2+, overall survival in these patients. You can see those Kaplan-Meier curves. And this is just a quick case of a patient with endometrial cancer that this was again presented at the SGO meeting, a patient heavily pretreated with multiple lines of therapy. HER2 was IC2+, that was treated in the second line with TDXD and actually received 50 cycles on the pan tumor in the Destiny Pan Tumor 02 trial, telling us there is efficacy in that IC2+. And if you look at NCCN guidelines, it actually tells you you can give TDXD in those patients IC3+ as well as 2+. When you look at cervical cancer, again, when you're looking at the progression-free survival in the IC2+, about 4.8 months, and overall survival in the 2+, about 11.2 months. And again, this is a case study of a patient with cervical cancer, IC3+, treated multiple lines of therapy and getting given TDXD on the Destiny Pan 02 trial, and you can see received 44 cycles before progression of disease, with best overall response of CR in this case. And again, when you look at the NCCN guideline, IC3+, 2+, it is recommended. When you look at ovarian cancer, again, in the IC2+, you can see a progression-free survival of 4.1 months and IC2+, 13 months overall survival. And again, when you're looking at the NCCN guideline, you can see it's recommended for IC3+ and 2+. Now, I'll just show you a patient of mine, 45 years old. She has recurrent ovarian cancer. I've kept her alive for about 5 years with multiple lines of therapy. I've just biopsied her, and her IC2+, for her HER2, her IC is 2+. And you can see that she has no other biomarker that I could potentially target. And I started her on trastuzumab deruxtecan, and I can tell you she's 6 cycles post TDXD and doing very, very well. And you can see that she's also not amplified in terms of HER2. Now, finally, what should we be aware of in terms of HER2 testing? And I'll only take a couple of minutes of this because I know I'm a little bit beyond time. One of the questions we ask is, what do we need to test for HER2? And like I said, you need to do the HER2 overexpression amplification, as well as, don't forget the mutations. It's approved in patients with lung cancer to give TDXD. And you can see, again, those various incidences of HER2 amplification, HER2 IH2 plus and 3 plus, as well as mutation across those solid tumor types. But essentially, the way the approval has come is that in breast cancer, you will do IHC plus or minus FISH, gastric cancer the same, CRC the same, in which if it's IC3 plus, it's positive, and if it's IHT2 plus, you do equivocal, that it means it's equivocal, you do FISH testing. But the rest of these patients, you only need to do IHC only, and if it's either positive or it's negative, you don't actually have to do ISH or FISH testing for the rest of those tumors. That's as per the FDA guidelines. Apart from breast cancer and the other solid tumor types, when you're trying to test for IHC in terms of seeing how to do the 3 plus scoring, all the Destiny studies actually looked at the IC scoring as per what you would do for gastric cancer, and that's what they adopted owing to the range of the tumor types and that were included to account for any resulting heterogeneity. We know that gastric cancer IC HER2 scoring is different from breast cancer. We know that there's increased tumor HER2 heterogeneity in terms of HER2 expression. We know there's variation in HER2 expression based on anatomical location of the tumor. And we know that the type of HER2 staining is circumferential in breast cancer. An addition of basolateral, there is addition of basolateral staining in gastric cancers. So what are the challenges that we face when testing for HER2 in gastric cancers, which is what we're using for other types of solid tumors? We know that there's spatial HER2 heterogeneity, where you have intratumoral HER2 heterogeneity, where you have differences also between primary and metastatic lesions. And we know there's also a temporal HER2 heterogeneity, where once you've given HER2 targeted therapy, a lot of these patients will lose their HER2 expression. I love this study. It's the variant study, which actually was a prospectively designed study in 35 German sites, where they looked at HER2 testing across these patients. And what they found was there was a 22.7% variation between central testing and local testing. Interestingly enough, the best cohort of patients who had the best overall survival were those patients who had both HER2 local as well as central that were positive for HER2 testing. So I thought very interesting results. But what was more interesting was that they were able to show thresholds for HER2 testing. In the IHC, you can see 40% was the optimal testing or staining to have that IHC 3+. And you can see for that HER2 amplification, the cutoff was 3, unlike the 2 that you see for breast cancer. So in this final slide of what does NCCN actually recommend, they recommend that you test all malignancies. But when you look at pancreatic, they actually have left it blank because of the rarity of HER2 testing. So I've put a question mark on this recommendation because I recently had a patient with pancreatic cancer that I sent for molecular profiling, and they automatically tested HER2 in this patient, and his HER2 is 3+, and I can tell you he's getting anti-HER2 therapy and has had a beautiful response with therapy. So as I said, if you do not test, you will not find. So what do you need to know about HER2 as an agnostic marker in terms of the questions that you will be asking yourself? First, is HER2 important beyond breast cancer? Simple answer is yes. HER2 expression is prevalent in a range of solid tumors and associated with a biologically aggressive tumor phenotype, poor prognosis, and increased risk of disease recurrence. Is anti-HER2 therapy active beyond breast cancer? I've shown you that, and the simple answer is yes. Is HER2 now an agnostic marker? Yes, TDXD has shown tumor agnostic activity on patients with HER2 3+ IC with durable responses. HER2 IC is needed to identify patients that may benefit from TDXD. Is all testing the same? I've just shown you that it's not. Breast is separate from gastric and beyond. Does TDXD work in HER2 low disease? I've shown you it does in breast and gastric, and is probably going to look at it also beyond in those other solid tumor types. Many new HER2-directed ADCs and bispecific agents are now in development. And remember, it's not only about HER2 expression, overexpression, but also about HER2 mutations, especially in patients with lung cancer. So thank you very much.
Anshika, you're not audible. Hello, ma'am. Can you hear me?
I can hear you.
Oh, I don't know. Anshika,
I can't hear Anshika, but I can hear you.
strange. Anyway, no problem, ma'am. Anyway, there may be some issue at her, technical glitch at her side. Ma'am, fantastic lecture as usual, and such a wonderful session. And let me see if there are any questions, because Anshika, if there are any questions, can you please paste in the chat box here, because I cannot see the participants. Finally.
Yes, sir.
Finally, acha, Priyanshi. Ma'am, till the time they ask some questions, maybe I can put forth a question to you myself. You said, right, that for a pancreatic cancer patient, there was an excellent response?
Yes, absolutely. I mean, if you look at pan tumor, they did include patients that were pancreatic. Obviously, there were not that many, and the responses were not that high as well.
Right.
But FDA has not restricted it to only certain tumor types. The FDA has given it to you as a blanket approval for all solid tumor types based on the pan tumor collective analysis, not only pan tumor, but obviously on the Destiny studies as well, and CRC, as well as lung cancer. So I've tested, and I can tell you it's not that common, but I have a couple of patients with pancreatic cancer where HER2 has been overexpressed. And in this particular patient, we have given him anti-HER2 therapy. We've actually combined trastuzumab and pertuzumab with his first-line chemotherapy, and I was shocked at how quickly he responded. And he's an elderly gentleman, has done very, very well. And upon progression of disease, I will have no qualms about shifting him over to DDXD in that second line setting. So like I said, this is the era of precision medicine. If you don't test these patients, you're not going to actually find the HER2. And I've actually had sit down discussions with my pathologist stating that it should now be a reflex test. Any patient that has a solid tumor that you're getting the report back for should have two IHCs that are agnostic. One is MMR, the second is HER2. We seem to have adopted MMR testing for everybody in terms of IHC, but for some reason, HER2 is not being reflexly tested. And that shouldn't be the case, because the percentage of patients that have MMR deficiency is the same as the percentage of patients who have a HER2 overexpression. So it should be a reflex test for all patients.
Very nicely put, ma'am. So would it be fair to say that every solid tumor should undergo HER2 testing?
In my humble opinion, yes.
Thank you. Thank you so much for that. Ma'am, so there seem to be some questions, so let me put them across to you. What do you think is the stand of HER2 low in other solid tumors?
So a very, very, very good question. So breast cancer, 100% low. We now have approval. We have good responses. Gastric cancer, you've seen the Destiny gastric trial, which I presented last week and now again today, that actually shows that there is some benefit, not very high. And I have to admit, off protocol, I have actually used it in some of my patients who've had 2+, not 1+, but 2+-ish negative. I have used it and I've had some decent responses, although not very durable. It is being investigated in larger cohorts in clinical trials. Unfortunately, when you go back to the pan-tumor studies, we have seen, away from gynecological malignancies, non-gynecological, beyond gynecological malignancies, we haven't seen that much of a response in the HER2 low. But in gynecological malignancies, and I was on a call with Fundameric a couple of months back, where I actually asked the question, how many of those 2+s were actually ISH positive versus ISH negative? And she didn't have the data for that, but she said it was a mixed bag, but they still saw responses. And if you look at the NCCN recommendation, it says cervix, endometrial, as well as ovarian. If you get IC3+ or 2+, and if I'm not mistaken, I think it's also 1+. You can actually give trastuzumab deruxtecan in these patients, and that's what we've adopted. We won't do it early on. Obviously, they have to go beyond first and second line therapy, but we have used it, and it does tend to work. And we're seeing some very similar responses to what we've seen in the pan-tumor O2's trial.
Okay, thank you so much for that, ma'am. And also for some tumors, you do not really have a correlation between the HER2 amplification and HER2 overexpression, isn't it?
Yes, we don't. So you have IC3 pluses that don't have actually amplification. And if you see the FDA has specifically said it's IC3 plus. They haven't mandated that you actually test for FISH or ISH in these patients.
Right, absolutely right, ma'am. Thank you so much. There is one more question. In the absence of HER2 mutations, only IHC HER2 expression, is it significant? So tumor types not specified here.
Of course it is. Of course it is significant. If that is the whole basis of everything that I've said today.
Yeah.
IHC3 plus is significant. Please give trastuzumab deruxtecan, and I'm only saying trastuzumab deruxtecan because it's FDA approved, but there are going to be other agents that are going to come out in this particular realm. Of course, like in lung cancer, you can have mutations as well as expressions, and it's approved for both. In breast cancer, we've had a lot of data for HER2 mutations. Komal Jawahiri has presented some very nice data looking at lapatinib and neratinib in patients with HER2 mutations and breast cancer, and it's worked in combination with endocrine therapy. So it's an emerging field. HER2 mutations are being explored across solid tumor types, but the only data we have right now is for breast as well as for lung cancer.
Thank you, ma'am, for that. There is one last question. What was the HER2 reporting guidelines for lung and colorectal?
So I'm sure there's a pathologist online right now that will be better equipped to answer this. I can tell you that when I go to my pathologist, they'll say it's not the same as breast. Breast is in one bucket. Everything else is in a second bucket. And that, if you pan-tumor and all the Destiny studies actually extrapolated from the testing guidelines for gastric cancer. And that's what they use for across solid tumor types. So you have two buckets. You have breast, and then you have gastric. And as I showed you, the guidelines for gastric, the threshold is different compared to breast. So you have your pathologist will obviously know more about it. I'm not a pathologist. My pathologist regularly screams at me and says, Shahina, don't try and interfere in our work. But again, this is the guidelines.
So, ma'am, your pathologist would use a gastric scoring system for other tumors?
Yes, they would.
Super. Okay, ma'am. So, ma'am, thank you so much once again for a wonderful talk, taking time out of your incredibly busy schedule. Like you mentioned, you woke up at 4 a.m. today to prepare this. And we really appreciate the effort, ma'am. Thank you so much. And you have agreed to be our panelist also today. So thanks for that also. So I'll now hand it over back to Anshika. Hope we would be able to hear her now so that she will take it forward.
Am I audible now?
Yes, you are.
So thank you so much, ma'am, for your talk. Now, moving ahead with our agenda, I would like to invite our moderator for the evening, Dr. Shyam Agrawal. He is a chairman in the Department of Medical Oncology at Sir Gurugram Gangram Hospital, Delhi. And our panelists, Dr. Shaina Daud ma'am, Dr. Sai Vivek, Dr. Vinita Pant, Dr. Harvind Kaur Glati, Dr. Devmalya Banerjee, and Dr. Sonali Nayak. Over to you, sir.
Okay, so good evening. Wonderful talk as always, Shaina, from your end, and very exhaustive and a lot of information on a variety of tumor types. So Anshika, can you project the slides from your end, please?
1 minute, sir.
All right. So I think we have all the pathologists on board in this panel discussion, except for Dr. Shaina and Dr. Sai Vivek. So I think we've learned most of the things, but I'm sure there are going to be some discussion points in the of testing and maybe how to sort of go forward in terms of treating patients with HER2 positive variety of solid cancers. So I think the first few slides were related to the data which just was shown by Dr. Shahina. That was the pan tumor study, and then the gastric cancer and the colorectal cancer, lung mutations, and so on. So can we have the slides on, please?
Sir, there is a little issue in sharing. Just give us 30 seconds where the slides will be shared.
So I think the question was related to the testing part, which is what has been briefly discussed and shown also by Shahina. Since we have 4 or 5 pathologists on our panel, so can somebody highlight the differences between testing for breast and for gastric for HER2/neu? Can I ask Dr. Dev Malya, please? I think he's there. I think Dr. Harveen.
Yes, sir.
Please.
Yes, sir.
I
So
think-
good evening to everybody.
Good evening.
Yeah.
Like Dr. Shaina said, for breast cancer, we have the traditional scoring where we have to have a complete, strong staining for 3+ positivity, and the percentage which is required is more than 10%. But for gastric cancers, we have the same percentage. The tumor heterogeneity is much more. And apart from the complete staining, we can also take the basolateral staining as positive.
Exactly.
So those are the things which are different. Apart from that, there are many other systems like the FEDER, and for endometrial cancer, serous cancers, there was a cutoff of 30% initially, which we were using earlier before the SPAN track came, and the guidelines have changed a little. And now they have, all told us to do the staining according to the gastric guidelines.
Can we go 4-5 slides ahead, which shows you the staining patterns for various yeah, go 5. I think these were all shown by Dr. Shahina, so there's not much point in repeating them. Next, please. Next. Yeah. So no. Were there questions? I think there were slides on the staining also, which were incorporated. Yeah, right. This one, yeah. Can go to the next slide, please. So this is what Dr. Harveen. Next slide. No, I think the previous.
I think it was a previous slide.
Right. Yeah, where they showed the previous slide. Yeah, this one. So if you see here in the breast, so you need to have total complete staining for reporting as IHC 3+ in more than 10% of tumor cells.
Yeah.
Whereas, so Dr. Devamala, can you share your thoughts and explain about the staining in the surgical specimen in the biopsy specimen for gastric?
Sure, sir. For the surgical specimen, basically, we call the IHC 0 if there is a no reactivity or membranous reactivity in less than 10% tumor cells. Faint, barely perceptible, these adjectives are important. For the biopsy specimen, we call it IHC 0 score if there is a no reactivity or no membranous reactivity in any tumor cell. So to call IHC 1+ for the surgical specimen, the criteria is faint or barely perceptible membranous reactivity in more than equal to 10% of the tumor cells, and cells are reactive only in the part of their membrane. So it's not the complete basolateral or lateral membranous staining. This part of the membrane staining is adequate for the call. It's the 1+. For the biopsy, the cancer cell clusters, and the definition of clusters is it is at least 5 cells together with the faint or barely perceptible membranous reactivity, irrespective of the percentage of the tumor cell stained. For IHC 2+, for the specimen, it's a weak to moderate complete basolateral or lateral membranous reactivity. So complete basolateral or lateral membranous is important, and the intensity should be weak to moderate in more than 10% tumor cells. For the biopsy, the same adjectives, but here 10% tumor cells not required. Only the clusters that include at least 5 cells positivity is enough. And call something the IHC 3+. Everything is just like 2+, only the strong instead of the weak to moderate. So one thing we should keep in mind, that breast cancer, it's a very much heterogeneous in the immuno profile wise. So the multiple area should we search in the high power 40x objectives before called something absolute negative. That's all.
Right. So I think, as you can see in this slide, IHC3 plus is, in the surgical specimen for gastric shows more than 10% of tumor cells, either complete
Complete,
or
it's not either
basolateral
side, it's a strong, complete basolateral or lateral membranous.
or lateral.
Either lateral membranous or the basolateral staining, but intensity should be strong.
So lateral is on 2 sides and basolateral is on 3 sides.
Yeah. Yes,
The
absolutely.
biopsy specimen, if you have, and there you have to have tumor cell cluster, which is defined as equal to or greater than 5 cells.
Yes.
So,
Yes.
Dr. Sonali and Dr. Vinita are also the pathologists. Any comment from their side on the staining patterns to define the IHC3 plus?
Same, sir. Actually, three things that we see: the completeness of staining, the intensity of staining, and the percentage of cells. So, like Dr. Devmailer said, percentage of cells in surgical specimen, we see 10% tumor cells, and in biopsy, because they're very small, tiny tissue bits, so we look for tumor clusters. Then completeness of staining, that like Dr. Devmailer said, basolateral and lateral, that comes into view now. And then the intensity. So this is how, I mean, Dr. Deval has actually very nicely told. So the three parameters that we usually see is the completeness of staining, the intensity of staining in the type, and the number of tumor cells which are picking up the staining. So this is how it is interpreted.
So it's
Yeah.
strong, complete, basolateral or lateral staining, right?
Yeah.
Or IHC3. And in the surgical specimen, more than 10%, and in the biopsy, a cluster of more than 5 cells. So what would be IHC2? Because as Dr. Shahina was referring, that patients can benefit, and there are NCCN guidelines for, NHER2 to be used in particularly gynecological malignancies and even in gastric and so on. So IHC2 would mean what for non-breast?
It would be like weak to moderate staining, which might be complete or can have, if it is gastric kind of thing, or can be, in case of endometrium, basolateral, lateral
I
staining is
think
also
there are like
considered.
4
So,
But the tumor
pathologists.
cell
Yeah.
number should be more than 10%.
yeah, so the only thing I would like to add on here is
Yeah.
first, for gastric biopsies, sometimes most of these are unresectable, and you were not able to get the resection specimen. So one of the important criteria for the Machado, the original article, they do mention that it's ideal to have at least 4 biopsy fragments with tumor. So that is one point. Of course, we do work in not so optimal settings. The other point is that in breast, they have given us a kind of a thing. See, if you see something at 2 to 4x, you see something at 5 to 10, 10 to 20x, and what you see at 40x. So that's like a rough. So if you see something at 2 to 4x, you know you're dealing with a 3 plus. If you see something at 20 to 40x, you still have to go to 40x and confirm. Then it's like a 2 plus, and what you see at 40x is like a 1 plus. But that's the rough guideline given for breast. I have not come across this in literature for the others, but that's how we. The other thing is, while we are talking of a very ideal setting, and we
Okay.
are presuming that all the pre-analytics are taken care of. So
Right.
my point
Of
is
course, the
that we are
fixation and the
talking of
formula, et cetera.
intensity. We mustn't forget that we are talking of, I work in a referral lab. So one of the biggest challenges we face is the pre-analytics, where you may call somebody which may have been 3 plus may end up being a 2 plus in your lab if it is not fixed properly.
Great. So I think the next question, which I think was alluded to earlier by one of the panelists, was does the gastric scoring apply for other solid tumor types like ovarian or endometrial, cervical, and so on? So, and of course, the question to the pathologist is that are you reporting your HER2 positive in these solid tumors, like for breast and non-breast differently, or I mean, is it become a part of the reporting these days for at least the bigger hospitals which are placed in metropolitan cities in our country?
Sir, in our hospital, Narayana Health, basically, we report the breasts separately and the non-breast, like your gastric, colorectals, and endometrial serous separately. So just in the talk, the Shaina madam
So,
told, there's two
thing is like
buckets.
gastric for non-breast.
Yes, the one is the breast and non-breast, all are like a gastric. And we
Okay.
mention basically in a reporting format, we write the detailed description. It is the percentage of the tumor cell, where we are getting it is a lateral or lateral membranous staining, and the intensity. All three particular adjectives we mention in our report, and then we give the score. In our hospitals in Narayana, we follow this protocol.
Right. So, Dr.
Yeah,
Vinita, yeah, anybody else wants to make a statement on this reporting? Because
yes, sir. Like actually, I was also trying to say the same thing. I generally, practice gynec pathology, and it is very important to write on the report what system are we using. If we are using the gastric system, we should write that we are using the gastric system for reporting this particular uterine cancer or endometrial cancer. If I'm using a fader system, I should use that. But as we know, this Destiny trial now mandates us to use gastric system. We should write gastric system that we are using.
right. So I think it seems that I mean, as a oncologist, we need to know, what system is being reported and what is the score, so that we can figure out, whether the patient is suitable for TDXD. So Shaina, at your place, are they also writing, gastric and the kind of staining and the score, etc., for your patients?
They do. They do. They give us that information in the report.
Right. So I think this information has to go down across medical colleges and all private institutions, because we have the availability of the drug and approval from NCCN guidelines. But then the reporting has to be correct, because if you are not reporting it correctly, you're going to miss the IHC3 and IHC2 in gastric and other non-breast solid cancers. So I think such kind of educative sessions are required, and I'm sure the pathologists are doing their training and their understanding, so that we get the right report. So can we have the next slide, please? Okay, I think this was again discussed, that in the panelist opinion, which scoring criteria should be used. I think we've covered. So I think it's easy to follow the gastric path, or should we do different fader and Hercules for other tumor types? Anybody wants to comment, Dr. Sonali? So are we happy with the gastric on one side, breast on the other side, and for the others like endometrial, colorectal, just have the the gastric one, the non-breast one, or should it be fader and colorectal and Hercules and so on?
Yeah, I actually have a question on this. Like 2 years before, 3 years before, we were using the 30% criteria for endometrium because that time we were having trastuzumab. Now the Deroxetin, it came up. So now we are using gastric. But, I mean, should we be informed by the clinician that what kind of drug he's supposed to give? And my question is, suppose the patient is not affording for TDXD, then and suppose affording for trastuzumab, then should I use a 30% criteria? That is actually my question.
Actually, to answer that question, ma'am, that's what I was saying. Earlier we used to use fader criteria only, and we were
Exactly.
using 30% cutoff. But now with this new CAP guidelines, in CAP guidelines also they have mentioned this gastric part. So if we mention in our report that we are using the gastric part, scoring system, I think that should be able to tell them, and if we give that information, they themselves will be able to derive the positivity or negativity. Like we do is ICE, like Madam was saying, Vinita ma'am was saying, intensity,
Yeah.
completeness, and the extent of the tumors. So it doesn't matter if you're using 30% or 10%, right? If we are writing 12% and it is a complete staining and strong staining, it will be fitting into the criteria by the gastric, right?
Yeah.
And the fat. So if you give this information in clear forms,
China.
the scoring will.
So Dr. Shaina, in the pan tumor study, where they had patients with IHC3, IHC2 for various solid cancers. So what was the methodology used for defining the score?
In
In
gastric cancer.
it was gastric cancer.
Gastric
They use the
cancer.
same pan tumor. All the Destiny trials, apart from the breast, have used the gastric cancer scoring guidelines. But I'd like to come back to that question of whether the oncologist should inform as to whether what treatment the patient is using and whether the patient can actually afford TDXD or not. And all I will say is pathologists shouldn't have any knowledge about what the patient can afford, what the patient can't afford, what the doctor is going to use to treat. The fact of the matter is all solid tumors, apart from breast cancer, all solid tumors need to have HER2 testing as per the FDA guidelines and also the ASCO-CAP guidelines and whatever guidelines that you use, which is the gastric cancer guidelines for testing. That's number one. Number two, if I have a gastric cancer patient who can't afford TDXD, they can afford trastuzumab, pertuzumab, you still have to use the same criteria for trastuzumab, pertuzumab in that particular patient. So it doesn't matter what they're using. The testing has to be standardized, it has to be uniform, and you have to put it in your report so that it informs the clinician. What the clinician does is completely separate. And if the patient can't afford TDXD, there's always a patient support program or something that you can eventually get your patient on, whether it's a clinical trial or a patient support program. So it's important that you have standardized testing.
Can I ask a question?
Yes, ma'am.
Yeah. So when we use the gastric criteria and give a 3+, you can use either the ADC or the trastuzumab. If we give a report of 2+, do we have to do a reflex fish?
For gastric cancer, yes.
For gastric, no. For the other pan tumor.
For the other pan tumor, so the FDA mandates that it has to be IC3+ for us to be able to use a TDXD, but for gynecological tumors, you should actually report the 2+ and the 1+. So what my pathologist does is they report 1+, 2+, 3+. We actually have that information. And as a clinician, I then have the prerogative of doing something with that information.
Okay, why I asked the question is because fish criteria for some of these tumors is not very clear, because especially in endometrial and all those, there are only a few studies. So that's why the reason I asked this, are
But
we
for
supposed to go for
gastric,
reflex fish?
but for gastric, it's
Gastric is
established,
clear.
right?
Gastric,
Yes.
breast are
Gastric is
clear.
clear.
And
So
the
for
others
gastric,
also have mentioned some criteria. So it's not that they're not consensus
in
criteria,
pan
I would say.
tumor, but in pan tumor with the FDA guidelines, you don't need to do the ish and the fish testing.
We don't have to. You should not recommend reflex fish. It's the prerogative of the. Okay.
Exactly. So the reflex testing should only be the IHC for
IHC.
all tumors and for gastric and for breast. That's
Okay.
it.
Because we in our breast reports of 2+, write that reflex fish is advocated. So that is why I wanted to ask this question. So as I understand it, that is not to be put in the other pan tumor.
Not that I'm aware of, unless
Okay.
unless someone else has more information. Not that I'm aware of. No.
Okay.
That be applicable to breast and to gastric, but not to the other tumor types. So I think we have Dr. Sai Vivek, who has not spoken so far. So
If I may just clarify, in the Destiny CR02 trial, I'm just looking at it again. They did include patients with ISH positive disease. So for also colorectal, you're supposed to do it.
Okay.
Yeah.
Right.
Good evening, sir. I think it has been a wonderful discussion. So I've just been a good audience listening and imbibing everything. So I think back here in Bangalore, we do test HER2 for almost all metastatic cancers, and it's become a I think agnostic marker. So, and we are following the gastric thing for everything except breast cancer, and it is reported as 1+, 2+, or 3+, or 0. So I think that is pretty much sorted.
Yeah, absolutely. I agree. I think most of the oncologists are now asking for MSI and HER2/neu by IHC for all our patients who have metastatic disease, so as to figure out whether they can be candidates for immune checkpoint inhibitors or for anti-HER2/neu therapy. Can we have the next slide? I think we are okay. So there was a question on the expression and mutation, etc. So Dr. Shaina, what do you say? So do we go beyond IHC for all our patients with metastatic disease to detect mutations and amplification by NGS?
So, strictly speaking, you should only do it for lung cancer and breast cancer because we have data to show that there is targetable disease that's targetable. There are trials currently undergoing right now that's looking at HER2 mutations in other solid tumor types. Having said that, I've always been an advocate that every patient with metastatic cancer, in an ideal world, every patient with metastatic cancer should have full molecular profiling, and you would automatically know that information on HER2 mutation. And if you have that patient with a HER2 mutation, you have to take that report to a molecular tumor board, and I can't imagine that someone would say don't use TDXD in that patient if it's not lung or breast. Having said that, it's not standard of care, and if someone didn't do it, it's not wrong. But in a comprehensive NGS, you will automatically get that information anyway.
Dr. Sai, any experience on CJP and picking up HER2 mutations, or I think we do find amplifications, in the NGS.
Yes, sir. I
Yeah.
think for more and more comprehensive panels, if you're using in metastatic settings, we are finding it. But as Madam was telling us, I think right now we are looking at mutations only in lung and breast. The rest of the tumors, I think it's much more easier. Look at the protein expression by IHC and then take a decision.
So, Dr. Shaina, if you don't find, IHC positivity and you do the NGS and you find amplification there, I mean, the number of copies are more. Would you honor that with TDXD?
Honestly, no.
No?
I don't think we have any evidence that it works in that sort of a setting. When the opposite is true. I've sometimes done NGS, and like you said, that I've seen amplification by NGS. I will go back to my pathologist and say, can you please do an ISH or a FISH and find that amplification? And only if they find it, then I will treat.
So I have a question here, sir. I mean, just
Yes,
going
sir.
by the central dogma, I think if it is an amplification in the DNA, it should at some point reflect in the protein expression by
It should.
IHC. It should. So if
It
it's
should.
not reflecting, that means probably a testing methodology has to change. Or it is not a true amplification. It can only be one of these two.
Yeah, the DAISY study, where you had no IHC positivity, the fair number of patients benefited from TDXD. So, Shaina, what do you say on that?
So those were the patients with HER2 ultra low disease. That's why they benefited, because in the DAISY, they only classified patients with HER2 positive, cohort 1, HER2 low, cohort 2, and IC0, cohort 3. But that IC0, when they went back and they looked at it, the patients who were really benefiting were those patients with HER2 ultra low disease. That's how the whole classification came about, that even those patients. So for me, HER2 ultra low, I go to my pathologist and I say, okay, you've said it's IC0, but I see one brown spot there. That is HER2 ultra low, right? So I think those were the patients that actually benefited.
Right.
Can I say something, sir?
Yeah,
In this
Dev.
regard? Yeah. See, basically, when there's approximately, if there is a IHC 0, that means normal cell, which is not a malignant cell, they also have the HER2 molecules on their surface. So IHC 0 means
20,000.
it is
20,000
at
of
least
them,
20,000,
normal
exactly.
breast.
Exactly. So there is a it's a 1 plus means it is a 1 lakhs. If I'm not wrong, 2 plus means 5 lakhs, and 3 plus something something. So
Absolutely.
that means that some extent of the molecules are there when it is still IHC low. So that's why it works. The TDXT is working.
Yeah, absolutely. So that we don't know the cutoff at this point in time. So that also, brings us to another experimental issue of proteomics, looking at,
Exactly.
of course, is highly experimental at this point in time. Can we have the next slide? I think we are run over time. So these are the same questions which we were. So the overlap between IHC and HER2 mutant tumors. So any comments by any of the pathologists here, Dr. Harveen or Dr. Sonali?
So, one thing I would like to say is that HER2, like when we are doing NGS, generally we are talking about HER2 mutations. Very rarely NGS is, also identifying copy number variations, which can amount to detection of HER2 amplification also by NGS, which can be done, but most of the times in the target, in the panel, we don't have copy number variations which can be detected by the NGS panel.
So do you agree, Dr.
So,
China, with this statement? So you're supposed to find IHC amplification if you're having IHC3, because the number of copies of those HER2 gene are going to be more, only then there will be expression on the IHC. Dr. Shaina?
No, I agree with you, but I also think you get a lot of false positives when you have a HER2 mutation.
Right.
So I've
Right.
frequently had patients with HER2 mutations, and their fish is positive. And the reason why the
true.
fish is positive is because it's a HER2 mutant. It's not actually a true HER2 amplification. So I think you have to be very, very careful of that.
So the HER2 mutation can, result in the, the IHC
Expression, right.
positivity of the protein. The protein expression is there. The gene is mutated, the copy number is not there, but then the protein is being expressed.
Correct.
That will be seen on the IHC.
Yeah.
Yeah, I think somebody wanted to, Dr. Dev, Malia, or somebody wanted to say something. Okay, can we have the next slide? If there's Dr. Sai Vivek, any comments here?
Nothing at this point, sir. I think the more and more, I think we have to test it. Only then we're going to
Question
get
is for
better.
you, Dr. Sai. Would the panelists consider TDXD in lung cancer if IHC3 or they're activating mutations or there's ERB2 amplification? So what do you think?
I think mutations, yes. And I'm a firm believer that if it's IHC3 plus being an antibody drug conjugate, that's when we are going to get the maximum responses. So once I think HER2 IHC3 plus and activating mutations is what I would be looking at in lung. I'm talking about only in lung.
What about amplification? Dr. Shaina? Yes or no? Patient has exhausted everything. All treatments are done. All chemo, immuno, everything is done.
So, I mean, you have the FDA approval to be able to give TDXD in this patient. So it's a no-brainer that you can give it in IC3 plus, you can give it in activating mutations, you can give it in HER2 amplification. So you have the pan tumor, but you wouldn't typically do HER2 amplification to begin with in a patient with lung cancer. You would do only testing of IC3 plus and activating mutation.
No, but then the report comes with your CJP, when you're
Yeah, but
asking
you can.
for. Yeah.
I mean, for me, with lung cancer, first of all, the response rates are not very, very high. But yes, I would, the FDA approval is there and I would use it.
No, right. So thank you. So I think we've covered most of the things here. If there are any questions from the audience or, from the panel, I think we're all here.
So may I add a
Please.
comment here?
Please.
So we have been talking about scoring and how do we score. But what Dr. Vinita also brought out was the pre-analytical issues which are there for reporting. So there are fixation issues. There are the which platform we have to use and what clone we are using and what protocol we are using. That has to be really, really standardized to bring out these subtle differences in IHC staining. That was my comment.
actually we have to mention on our report actually whether you have the cold ischemia time, whether the fixation. So so in these situations I do, at the risk of being unpopular, I do mention if it's a suboptimally fixed tissue. So in your report, at least in my report, I do mention if I feel that there is a pre-analytical variable which is not satisfactory, including the status of controls. So a complete report, as far as I'm concerned, includes the information on pre-analytics, whether it's satisfactory or not, my interpretation of the report, and what my reference is.
Right. So I think the details of the pathology in terms of fixation, the time period between the removal of the specimen and putting in the formalin. So all that needs to be should be standardized in order to get the best results from the pathology. There are many questions in the chat box I can see here. Sometimes Dr. Trupti again NGA shows amplification of high copies and still IHC is asked. Is it needed? Why? I think we answered this. Dr. Shaina, you want to take this? Should we, if you have NGS amplification, so IHC is so easy to perform. Dr. Shaina, would you like to confirm IHC?
Yes, you
Okay.
have to. I mean, that's what the trials did, and that's what the approvals are. So
But
you
that's
have
where
to
the
do it that
that's where the drug
correctly.
binds. So the drug binds to the protein on the surface of the cell, and IHC tests that, right?
And
Uh,
yeah.
Right. I think the questions are now coming fast. Do you recommend HER2 staining in endometrioid carcinoma, FIGO grade 1?
It's for all endometrial cancers.
Yeah, in stage metastatic disease. So these
Yes.
all have metastatic disease.
But then, at the same time, endometrial cancer in itself, the new classification is that you should be doing all the molecular markers from the very beginning. And so endometrial is a different subset of patients, but yes, in terms of therapeutic intent, all metastatic should be tested.
So do we use, and if we use gastric type scoring for non-gastric cancers, then do we use same for biopsy and resection? I think so.
No,
No.
for biopsy, it is different. Like for gastric, scoring system was different for biopsy and resection.
Yeah. So for non-gastric, would you use a different, scoring system for biopsy and resected specimen?
Yes, that is what is recommended in the recent CAP guidelines for endometrium and other tumors. It has been updated. It is like gastric.
Yeah. So I think one needs to perhaps go back, and there has to be some uniformity. This new drug has created a lot of sort of learning points and discussion points between the pathologists and the treating oncologists and so on.
So that's what I was trying to say initially also. Intensity, completeness, and the extent of staining. If we give that information, we will be able to derive the scoring system or our own, whether it is gastric or non-gastric or Natalia Busa, as I can see in one of the comments, Fader, Hercules. If you're giving this information, and even if we don't write 1 plus 2 plus, anybody can understand according to gastric what is the scoring. And so if we can give that information, it will be good.
Okay. I think we can take this last question. If lung IHC is 1 plus or 2 plus, no mutations or amplification NGS, can TDXD be given? Dr. Sai, will you do it?
I think in a later line setting, yes. I think 2 plus definitely. I think the response rates I know, but when it comes to going back to conventional chemo, I would say some bystander effect is better than none.
Dr. Shaina? So lung cancer, IHC 1 plus, 2 plus, will you use TDXD?
No.
Never?
It's not never. I think it's being explored right now, but I think the probability of a response is going to be very small. In the Destiny trials for lung, they included patients 3 plus and 2 plus, but really the majority of the response was in the 3 plus patients.
Okay, Dr. Archana is asking what is the difference between amplification and AMP oblique overexpression of HER2. So I think you need to perhaps go to the basics a little more. So I think we've answered most of the questions mentioned in the chat box. From the AstraZeneca team, is there any more question before we come to a close of this interactive session?
No, sir. I think that's about it, and no more questions. So,
Thanks to Dr. Shaina for taking all the questions and for the wonderful talk and enhancing our knowledge on the evolving subject of HER2 positivity and the use of this new drug HER2. So I think it's really expanding very rapidly. Thank you very much.
thank you so much, Sham sir, Shaina ma'am, Sai Vivek sir, Vinita ma'am, Harveen ma'am, Sonali ma'am, Devamalya sir, everyone, all the panelists. Vinita ma'am, thank you so much for taking time out of your busy schedules and for being here, having such a nice session and a panel discussion and answering all the questions patiently. Hope I have
Thank
not
you.
missed
One
any.
always learns in these setups. Clarify a lot of doubts.
Yeah. Thank you so much.
Thank you.
Thank you so much.
Thank you.
Thank you.
So that was a good discussion.
Thank you, ma'am. Thank you for being here.
That was very good. How many people attended?
I need to check the last count was 105, but I'm sure it would have gone up. So I need to check that.
137, sir. 137 last count.
That's good.
But we
Thank
have
you.
also crossed 200, 300 earlier for your earlier
In
session.
last webinar, yeah.
All right. Okay. Thank you. So the next one's on Monday. I'm not sending you anything until Monday morning.
Sorry? Slide deck, huh?
Yeah, Monday morning. Monday morning.
Yeah, ma'am. Our routine is set now, ma'am.